I guess we'll start. I'll introduce myself and I'll try to enable you to get an early idea of what I intend to talk about. My name is Jonathan Grunfeld. I'm a neurologist by training with a fellowship in neuro-oncology. But I am primarily busy in palliative care in an oncology department. So I am not an oncologist, and I am not a scientist, okay? The reason that I am here is that I have clinical experience providing or administering or licensing cannabis for a broad variety of patients with cancer. And based on that, what we have here is essentially, as far as I can tell, a workshop in mind. That is a situation in which we sort of try to discuss and elaborate our concerns with the use of cannabis for oncological patients, with me in this position based on clinical experience. I mean the numbers are impressive, but the question is what that translates into. I have experience of close to 2,000 patients with cancer. I have experience with several hundred patients with other ailments, but that is less relevant in this case. I'm working in Israel, but I am definitely not representing the official policies authorized in the State of Israel, although I do possess the authority to issue permits on my own for oncological patients. Also, we should notice that this workshop is sponsored by Better, which is a company which produces cannabis. I am somewhat associated with another company that is talking about development of an apparatus, and I have received some honoraria in the past. Okay, so basically, you know, what's the issue? What does cannabis have to do with oncology? And then I say who is asking and who is answering, because as you can see, there's public pressure on the one hand and professional literature on the other hand, okay? So actually we are dealing as clinicians in the field with an encounter between the layman, the public, and the clinician, the professional clinician, backed to a greater or lesser extent by modern medicine with an affinity to science, a proclaimed affinity. As clinicians, we are performing an art that has to do with skills more than science, but we are definitely supported by findings of science, and some of the conclusions that we depend upon from research are arrived according to more rigorous studies. And we will discuss somewhat this encounter between the physician and the patients from the perspective of the encounter itself, the experience of the patients and their mistrust. And then I'll mention some benefits that I have observed of the use associated with using cannabis for oncological patients. And we'll focus on what I call the clinical synapse. Okay, the clinical synapse is the contact, really, once again, which I have mentioned, between the physician and the patient. More on that later, I guess. So, is there a place for treating patients with cannabis, cancer patients, that is? And, you know, it's a question. Google is one way of assessing the extent of concern with this sort of issue. And here are the numbers. Cannabis and cancer, you get 19 million hits. If you just go for cannabis cancer cure, you get 826,000 hits. And if you go for, let's say, Rick Simpson, you get 370,000 hits. So there is a significant concern with this issue. And Rick Simpson is, I think, in this point, there's a so-called Rick Simpson oil, which epitomizes the hopes that many cancer patients have, that they hang on the use of cannabis, because this is a popularly conceived remedy for cancer. Some observe it and read about it in more rational fashion, others more in the form of a religion, I could say. But the fact is that on the internet, in the YouTube, there are many reports of people claiming that notorious forms of cancer, lung cancer, pancreatic cancer, have been cured by a certain concentrate of cannabis oil. One of the examples is of a scientist in a reputed cancer center, okay, who was diagnosed with a progressive cancer of the prostate. And he treated himself with cannabis oil. That is his report on the YouTube. Okay, so here we are at this convention and we're talking about the YouTube. But this is our daily experience and this is what we have to deal with and come up with reasonable responses for our patients. And of course, in this case, this academic, biochemist, I believe he was, cured himself of prostate cancer using this cannabis oil. And if we go into the literature, the professional literature, there's not much, but there are some investigations into potential mechanisms by which cannabinoids can impact tumors. This is not the theme of this workshop, of course, because I am not a scientist and I am not going to detail what I know and definitely what I don't know. But we should be aware of the fact that there is a certain rationale. Okay? So let's say this report suggests that CB1, CB2, receptors that is, could be used as novel therapeutic targets against non-small cell lung cancer. Okay. Another report, a recent report, has been published on the effect of a combination of cannabidiol and tetrahydrocannabinol, that is THC, together with radiation. And in a model, an animal model in mice of the most lethal brain tumor, responded dramatically in unprecedented fashion to a combination of cannabidiol, THC, and radiation. Okay? And cannabidiol itself, that is CBD, right, or THC alone were not effective. But when they were combined together with the radiation, then they observed this effect. This is another example of, you know, the ongoing research. There's much more. There's an extensive literature behind that. Not to the degree that you find on other preparations, but still, it does lend a sense of legitimacy to hypothesize on the effect of cannabinoids on cancer. Another recent report in the field of hemato-oncology reported on the response of a young girl with progressive leukemia. She was beyond treatment. And the parents appealed in Canada to the doctors to attempt a treatment for her with cannabis. And there was a remarkable response, which can be monitored. It is not that she felt better or something like that, not that alone, but the counts of the proliferating cells went down. The genetic follow-up provided evidence that there was an improvement in terms of that disease, and she was in terminal state. Ultimately, she did pass away, but still, the data that were presented in this case report, I emphasize, okay, this is not a trial, this is a case report, are suggestive at least that there is an interface between the use of cannabis and proliferative malignant diseases. So at least it gives impetus to go on studying the subject, and of course is translated in the public mind into so-called proof that cannabis cures cancer. And cancer in the public mind is just one entity. It is not 1,000,001 different diseases with a different, unique pathology, pathogenesis, biology in each and every disorder. And I'm not talking about the difference between the individuals with so-called who are afflicted by the same entity. Okay. This is the girl. So this is the case report. I'm sorry, I sort of ran ahead. This is a review on the topic, and there are several such reviews which should be updated from time to time because research in this field has been expanding over the last several years. So this is just an example to prove that there is some basis to this assumption that cannabis is effective as a therapeutic agent for cancer. And I can present to you some cases from my service. These cases are presented here to illustrate certain situations in which the patients perceive their use of cannabis to be healing them. I cannot substantiate that claim, but it is their experience, and they go on to tell that story to their friends, to their families, and, you know, rumors spread fast and wide. So this is a young 42-year-old with papillary carcinoma of the thyroid, and she was treated several times. She has a resistant disease. She underwent radical resections, is suffering from a severe pain syndrome due to the resections in the neck with a prominent neuropathic element. And of course, she has repeated follow-up with imaging studies as well. And she was identified to have 2 remaining large lymph nodes assumed to be involved with the tumor. After starting treatment with the cannabis, a long time after she had received, over more than a year after she had received her last dose of radioactive iodine, she was observed to have an alteration in the size of those lymph nodes. Okay? They were not resectable because they were adjacent to large blood vessels and were considered unapproachable from a surgical point of view. In any case, one of the lymph nodes disappeared in the imaging, and the other one was decreased in its volume to about half the size. The patient attributes that to cannabis. Okay? What can I say? Normally, such lymph nodes, which were consistently growing and growing and growing, would not resolve. So there is a question. We have no reasonable answer. All we can do is report a certain observation and try to think about it and maybe plan a way to investigate this issue further down the road. A 38-year-old with a pilocytic astrocytoma in the pineal region. This is a midline tumor, which is not characteristic of people of such an age. He was diagnosed as a grown-up. This is essentially a tumor which presents in the childhood and is considered a low-grade tumor. If you resect it completely, it is not expected to recur in most of the cases. However, it was situated in such a position that they failed to resect the tumor entirely. And he is suffering of severe headaches. And he has been receiving cannabis for the headaches, because cannabis is very efficient for the management of headaches. And there was this observation of a decrease in the dimensions of the tumor. Is this a spontaneous regression of the tumor? Is it a response to the cannabinoids? We could not tell. If we are serious, scientists will say, okay, there is this observation, I don't know, but we have to repeat it and we have to do some investigations to see if it makes sense at all. Of course, in the eyes of the public, here is a progressive response of a tumor which cannot be managed by any other means to treatment with cannabis. Okay, now here we have something a bit more obvious, because we have the opportunity to treat this man. He's in his 8th decade of life and he has severe BCC, basal cell carcinoma in his skin, all over the scalp, in his face. Half of his ear has been resected due to these skin tumors, all over, full of scars. When I saw him, they were itching, there was an exudate, they were bleeding. They tormented him day in, day out. In this case, he applied cannabis oil to the lesions. Now, there's a unique interaction between cannabinoids and skin lesions. Okay? We know that there are receptors and keratinocytes, etc., and there are many other skin disorders which do respond one way or the other to cannabis. Once again, not something that has been established in an evidence-based manner, but it has been frequently observed, and with outstanding effect that it would be hard to say that it is a chance response. In this case, he applied the cannabis oil to these lesions, and they resolved to the extent that they were no more exudating any kind of fluid. They were not bleeding anymore. They were not itching anymore. He could go to sleep and wake up in the morning with a clean pillow. And in his case, for bureaucratic reasons, there was a break in the treatment, and then the lesions recurred. And once again he got access to the cannabis oil. Once again they went away. So we have challenge, re-challenge here, which is suggestive that it really is effective in this case. Another lady with breast cancer, with a large lesion on her breast, or where the breast had been, because it had been resected, but there still was a local recurrence. And the skin was not there anymore. It was a raw, open sore. The size, I have assumed the dimensions of 20 by 10 centimeters, a large lesion, and she was on active treatment with Xeloda at the time. Received no other intervention for this lesion, which was painful for her and irritating. There was quite significant neuropathic pain there as well. She started applying cannabis oil, and the lesion resolved. Now she is not cured of her metastatic cancer, but she is no longer with an open sore. The skin has completely healed over, and she is without any further pain, without any itching, without any unpleasant odors. So we could discuss this in the context of palliative care, but we can also discuss this in the context of oncology, because the lesion that had resolved was not just an abrasion, a scrape of the skin, it was a cancerous lesion. And in this context, what we encounter as clinicians is an appeal from the public. They come to us after reading about Rick Simpson oil performing wonders in the YouTube, in the internet. There's an entire subculture of people providing information from one to the other about the efficacy of cancer, to the extent that patients come to my clinic sometimes. You know, there are mainstream individuals, and there are people on the fringes of society. And they come, and they will practice Ayurveda, and they will want all kinds of alternative therapies, and they will not hear of receiving any kind of so-called conventional therapy. They refuse it. Even hormonal therapy, nothing, okay? And they come, and they don't trust the physicians. The physicians are agents of the dark forces of modern alienated civilization or something of the sort. There are variations on the theme, I can imagine. And then we have no cooperation with these patients. Often they get lost. They don't come to see doctors anymore. They go off into the mountains, see their friends, travel abroad, go to Mexico, go to India, try a mushroom here, peyote there. And I'm not saying that in a sarcastic sense. This is actually what happens. They are a small minority, but which is representative of a sentiment which affects a much broader section of the population, who possibly will collaborate with the doctor's recommendations to an extent, but have their misgivings. They do not fully trust the doctor. They simply have no other option, so they go along and comply with the pressures from their wife, mother, child, whatever. Okay? It is common for patients to turn up in our clinics in Israel and possibly in other places around the world, making the clear distinction between chemical medications and natural medications. And you can say, okay, there are many terrible poisons in nature, but they are natural apparently. They consider the natural preparations legitimate, and the synthetic human so-called chemical agents illegitimate, unacceptable. Okay? And this is an example of one of those women. And you can see the context. She was 40 years old. As a child, a growing adolescent, she had to take care of her mother, who was dying of breast cancer. So she was acquainted with this and disappointed with Western medicine, because she saw her mother obviously suffering terribly and ultimately dying. And she was opposed to any kind of treatment. She insisted on trying cannabis alone to treat her tumor. She would not even receive hormonal therapy. She refused it. She went home and insisted on this alternative, unestablished therapy with cannabis. Okay. And she comes. She only came to my clinic. She was not prepared to talk to doctors anymore, because obviously she had very negative experiences talking with these other doctors who said, if you do not comply with what we say, we will not talk to you. And then you have a problem you have to deal with on your own. She was abandoned by those doctors in a sense. Now the question is, since we are here in a workshop, how do you approach such a situation? would you tell that lady that, well, since she is not prepared to comply with your recommendations and you know that they are critical to her well-being and that she can survive much longer and suffer less if she takes that therapy, if she will not comply, you'll say you will not take responsibility for her and send her off? How many would do so? I have worded it it's bad wording, because the way I said, nobody wants to say that's what he would do, obviously, and possibly the population, the people here in this room, tend not to have such an approach to what they're doing. But the fact is that, as a rule, patients under such situations are sent home packing. They do not receive any further treatment. They are not even referred to palliative care. They are simply told, well, you are not collaborating, there's nothing we can do. There's that saying, you know, help me to help yourself, which is kind of condescending and very offending to patients of this sort, who will never return to a doctor who says to her, help me to help yourself. Because what can be more disempowering than such a statement? And now this, of course, comes into the context of how we deal with cannabis for oncological patients. So she insisted on natural therapies, and she stuck through to the end. She did receive some radiotherapy when her cervical spinal vertebrae collapsed and were very painful. But ultimately, she passed away. Another example. There's a 50-year-old male. He has an unresectable brainstem glioma. Gliomas are a field of investigation for use of cannabinoids nowadays. There is a sense, even in the scientific community, that possibly cannabinoids can be of benefit, so that research has been done on models, as we have seen before with the CBD and THC in combination with radiation, for example. And there have been other studies as well. This man comes in, but this is a low-grade glioma. It's not a glioblastoma. Okay, so we have to be aware of the facts, of these details when we are talking about whatever medical problem that we're dealing with. In any case, he has refractory seizures, and it is common with this form of low-grade glioma, seizing again and again and again. Despite all the efforts, and he went to the top neurologist who specializes in epilepsy in the state of Israel, and received every kind of drug that had the potential to control these seizures, and nothing happened. And then he turned up. I provided him with a license, and he turned up in the clinic. I will soon tell you how it works in Israel, how we actually work with this cannabis, how we recommend it, how it goes through. So in any case, he turned up at the clinic and sensed that he was starting to develop a seizure. He has seizures in his jaw and his neck. And he was starting to develop a seizure which became stronger and stronger. And then he started to get instruction about how to use the cannabis. And he took 2 puffs, and the seizure abruptly discontinued, was free of the seizure. Okay? It's a fact. And then, after a while, he spent there a while getting the instruction, the seizure recurred, and he took another 2 puffs again. And once again, the seizure resolved. Now there's another workshop, 2 rooms from here, on the effect of cannabis in the context of epilepsy. Okay, they're using oils of a certain constitution and so on, and it is possible the observations are supportive of a significant clinical effect of cannabis on seizures. Okay, so this is another example. Here, it assists oncologic patients cope with their disease and the accompanying symptoms. Now, let's say the woman who was 40 years old with a progressive cancer, she had no other option. That was a last resort. This man who had exhausted all options to manage his seizures turned to cannabis as a last resort. There's a difference when we are trying, from a practical perspective, when we are trying to manage uncontrolled diseases and symptoms. When we have nothing better to offer. If we have something to offer, then we can insist and say, look, this is not the way we practice medicine, if that is the way we see things. But if we have nothing better to offer, it is very difficult for us to justify our position vis-a-vis the patient in refusing to provide him with something that possibly can help him. Maybe not. Maybe it's just something that he believes will help him. Sometimes it is something that he already has experienced and says, look, this helps me, and still we refuse to acknowledge his testimony. So, these are the patients at the dead end. I found these 2 words, okay, to represent the situation. So, cannabis, we do not have significant clinical experience using cannabis as a therapy for cancer. There are suggestions, there are grounds to go forward and try to treat people in situations of a so-called dead end with cannabis for several reasons. We do not do that with other drugs in development. But people do not go out and buy drugs that are being developed in the black market on the street and poisoning themselves and funding the criminal world. Okay? So if they are already using such agents, if we provide them with regulated, consistent cannabis products, we are actually improving the situation, even though we are not acting according to some kind of scientific rule. But the situation, ethically, pragmatically, is a different situation. I have one patient who is a schizophrenic patient. They smoke a lot, and as such, they can develop lung cancer. And he indeed did develop lung cancer. Now, like many schizophrenics, they say that cannabis is bad for them and evokes their psychosis, on the one hand. On the other hand, he is going out to the street and getting all this bad cannabis and all kinds of synthetic substances. I cannot tell what he is getting. I have no control of it. On top of that, when we know a bit more about cannabis, we know that on the one hand we have the THC, which is a legitimate Schedule III drug, Marinol, in the United States. And on the other hand, we know that there is a CBD which can modify the effects, the psychotropic effects of the THC. So in this case of this schizophrenic patient, he received a prescription, a license for cannabis with a high content of CBD. And he is receiving it under controlled conditions. He is not getting a whole mass. He's getting a joint every so many hours per day from his sister, who was keeping the stash in her custody. And he has been doing well without any deterioration of his schizophrenia over half a year. And he is feeling much better, he is eating better, he is much more relaxed and coping better with life in general and his disease. So this has to do with the pragmatic application, pragmatic sort of approach to using cannabis in oncology and all kinds of accompanying situations which might cause us to hesitate and avoid using it. So, apart from the using cannabis as a treatment for the cancer itself, it obviously has a significant impact, which is on the symptoms of the patients, which can also modify the course of the disease. For example, patients with symptoms of nausea, sleeplessness, pain are restricted to the bed sometimes. They cannot eat at all, they are exhausted. And they are considered to have a poor functional status. And a poor functional status translates into the refusal to provide certain chemotherapeutic regimens, for example. They are not candidates for therapy because their disease has already progressed so far. Giving them the cannabis, you can improve their functional status. And then, if they are just presenting, let's say, with a pancreatic cancer or a cancer of the biliary system, then they transform from being candidates for a hospice or for long-term palliative care. They are transformed into candidates for therapy. So they can get Nexivar, so they can get whatever else. And the same if they have a crisis in the course of treatment of a disease, okay? The cannabis can also improve the daily functioning of such patients, which is sometimes instrumental even in the management of the disease itself, because they can get back and forth to get the therapy and things of that sort. Now obviously, this has to do more with the palliative care. Cannabis can improve the quality of life. This is a statement that I am making based on my experience, on my anecdotal experience with circa, well, close to 2,000 patients, cancer patients that I have treated. It is not a scientific statement, and I cannot make a scientific statement because I have a broad variety of many different patients with different medical conditions, different gender, age, comorbidities, and therefore it is impossible to make a statement that will be acceptable to a respected, peer-reviewed publication. I don't know what the concentration of the THC and the CBD is. I know grossly. I know that it is this species or that species. Sometimes it is tested to a greater or lesser extent. But over the years, these things have been shifting as of yet. And therefore, you know, I cannot tell, because what did they get? Did they get this or that or that? However, despite the fact that I do not know what the content of the cannabis, what the content of CBD, of THC, of other cannabinoids for that matter, is in the cannabis they are receiving, that prevents me from appealing to the scientific world. From a pragmatic clinical perspective, I can titrate the treatment to their clinical symptomatic response. And therefore, I have the tools, I have the ability to assist them improve their well-being, their functional abilities, their quality of life. And, well, I'm discussing, basically, I'm not discussing science here, I'm discussing clinical experience. So there are these examples of different constellations, and you know, there are certain patterns of of symptoms that are characteristic of different medical disorders or tumors. CML is treated nowadays with Gleevec, a wonderful drug. It saved people who previously would have died relatively soon after being diagnosed, and now they can live on and on taking Gleevec. However, there's a problem with Gleevec and with other more modern biological agents that do more or less the same, serve the same purpose of controlling this hemato-oncological disease. People who take Gleevec occasionally go on experiencing nausea, vomiting, poor general feeling, muscle cramps, weakness in their limbs, on and on for a very long period of time, to the extent that some of them discontinue this treatment at the risk of their lives. You give them cannabis, it resolves their nausea, it resolves these other symptoms of cramping and pain in the limbs. They are infused with more energy. I have a 34-year-old patient who goes out for runs now. He goes and runs, does sports. Before that, he couldn't walk, he couldn't sleep, he was feeling bad. Thanks to the cannabis, and there was no other drug that enabled him to achieve that level of functionality. So here we see that this is a supportive intervention that enables people to continue receiving a life-saving therapy. Patients with upper GI tumors, as I mentioned before, often have problems with eating, with nausea, with vomiting, with pain. Most of the patients across the board, including those with upper GI disorders, have problems sleeping at night. There is a consistent observation on the anecdotal level, of course, of such patients receiving cannabis, and within 20 minutes they sit down and ask for something to eat. And they smile for the first time in months, and they sleep at night. And the effect persists. It is not just a one-time response to the first exposure to cannabis. With lower GI tumors, anorectal cancer, patients suffer of tenesmus, for which we have no effective treatment. They have problems with obstruction. They cannot rid themselves of the feces. It is painful for them. They develop fecales, etc. You give them cannabis, you avoid arriving at high doses with opioids. They have less constipation, obstipation. Cannabis relaxes muscle tone. It can relax the tenesmus to an extent. You can apply oil locally to the sphincter. It assists these patients and enables going on to the extent that maybe they retain a functional status that enables persisting with an effective chemotherapeutic regimen from which they would have been discontinued otherwise. Pulmonary tumors. You know, it is a problem with cannabis, and I think everybody who hears of cannabis says, you know, it is not a panacea, and all these people who talk about receiving cannabis for treatment, for therapy, they are just believers. They believe in the magic of cannabis. They are not serious people. But the fact is that endocannabinoids really are active on very many different levels in the organism. From the skin, as I said, the keratinocytes, to the gastrointestinal tract, to the bladder, to the nervous system, both peripheral and central, to the immune system, to the lungs. In case of the lungs, cannabis itself appears to improve respiratory function. For example, people who are suffering of asthma and receive cannabis, even if they smoke it, I'm not talking about inhaling, have improved respiratory functions to the degree that they can discontinue their steroids and continue feeling well. And this has been proven with several of my patients, one of whom had such poor respiratory function that he came in a wheelchair with oxygen and did not have his cancer biopsied because they were afraid to puncture his emphysema. The next time I saw him, after he started treatment with cannabis, he was without the oxygen. Okay? He could, and people do not just stop using oxygen for demonstration, because the discomfort caused by such severe respiratory insufficiency will not allow him to put on a show. And other patients have been to pulmonologists and have gone through testing both before and after inhaling cannabis, and their respiratory function improves after inhaling the cannabis, even by smoking. Not only that, cannabis can also suppress the urge to cough. Sometimes patients with pulmonary cancer, lung cancer, can have incessant coughing. Now, initially they cough when they inhale, but after the initial exposure of the initial irritation, there is a reduction of coughing. Of course, there's good reason to recommend these people to use a vaporizer at least. Some of them will not give up the pleasure of smoking, but the thing is, you know, it is not a contraindicated. The biggest problem with such patients, of course, is when they have fractures in the ribs, and then they cannot even tolerate the initial coughing from inhaling even the vapor. Pelvic tumors also can frequently involve the nervous plexus, creating severe circumstances where the pain is very hard to control. Sometimes pain specialists will treat such patients, if possible, with all kinds of invasive therapies, epidural, analgesia, and so on, which is not always effective and is not always accessible. If they are thrombocytopenic, etc., you cannot start introducing these objects through the skin. If they are neutropenic, they will not survive the potential infection. And cannabis is effective in ameliorating and improving the coping with severe neuropathic pain, even if it does not eliminate it totally. Okay, it has an effect that enables people to go on functioning despite the pain. Sometimes it is effective in eliminating the pain, but not always. Sarcomatous lesions are also very difficult to manage in terms of the pain, and cannabis, for example, can assist those patients when all the other drugs fail. As far as CNS tumors, well, I'm not talking about the spine. The spinal tumors are an issue in themselves. A couple of slides earlier, I have mentioned the impact of cannabis on seizures. As far as the spine is concerned, cannabis can also help people with spasticity, and we can go on and on. So these are anecdotal data, but which cannot be ignored, especially if the patient comes in and reports his own experience, which in Israel can happen. Patients are wary of reporting that because they know that is not exactly legal, but if they have the confidence in their doctor, then they will discuss that, and then you have first-hand evidence that it is effective, and you have all the reason to try to help them get access to the cannabis. So this all has to do with interaction between the doctor and the patient. Okay? And how does it work? Many of the patients I get to see do not necessarily have any experience with cannabis, or possibly they had a joint once or twice in their youth in some kind of party and then never went on to use it. Some of them might have had negative experience, some might have persisted using cannabis for a long time, but many have not. These are different categories, and we have to recognize, we have to communicate. I mean, what we do as clinicians, first and foremost, is communicating with our patients, of course, and we learn a lot from them. And I think the question is how to exploit this option to its utmost, because we are dealing with people in a very difficult situation. For them, that is all they have. That is their life. And we are there. We can arrive at one decision or not, or another, and we can do that listening to them more or less. We can try to impose all kinds of norms of the medical establishment and just say we have no established proof from randomized controlled double-blind trials, clinical trials, and refuse something that they know from their own experience has been helping them. So there are different scenarios. One scenario I didn't mention here, but let's start according to this list perhaps. Okay? So I mentioned the stigma and the nocebo. Many elderly patients come in suffering terribly, nothing can help them. They are wary of using cannabis because of its stigma, of course, and they say no, and they repeat it all along. I have never used this, I will not use this. Some of them even receive cannabis because of pressure of their relatives and say, there, you see, I've tried it. It doesn't work. And then after a month or after 2 months, they come back and say, can you extend the license, please? Okay. So they somehow come to terms with using the cannabis and do identify some benefit in using it. Nocebo is that concept that I mentioned. The issue of balancing expectations is something also that has been mentioned before, right? Either you have a panacea on the one hand, something that creates excessive hopes, or on the other hand, complete disbelief and rejection of the option. And you have to, in this, what I described there as a clinical synapse, the encounter between the physician and those who receive his attention, actually as a collaboration, we try to direct our discourse according to their expressions. So we see their responses, we listen to their queries. Some are worried about the effect it will have. Others are demanding more and more. Sometimes the patients are kind of passive. They're overwhelmed. They are very ill patients or relatively passive, perhaps due to their personality or whatever other factor in their lives. And they have a wife, a child, other people who are opposed to something that personally they wouldn't mind trying. So we have to negotiate this with the whole family. We have to discuss it before making the recommendation. As a rule, I will never, and this is my personal experience, and perhaps my approach, but I will never impose a recommendation on someone who does not want it. I will not say, take it, it is good for you. I will say, there's this and this option, but not in the neutral, uninvolved fashion. I'll say, there are examples, this and this is really something that you could consider, but I respect your decision and I'm with you no matter what. And sometimes they refuse initially and come back later. And it's fine, you know, as long as we maintain a contact so that they know that maybe they can think about it, but they are free to change their minds later on and discuss it. This is, you know, it's clinical medicine in general, but it becomes more significant when you have to overcome these ideological and normative obstacles in the context of using cannabis. Then we have the issue of explaining the treatment. In Israel, we have two major options nowadays. One is inhaling the cannabis. Some prefer smoking. We try as much as possible to recommend inhalation rather than smoking. But, I mean, it depends on the context, once again. Some people say, look, I've been smoking this for 30 years. Just let's drop this discussion because I'm going to smoke it in any case. And you understand it. You say, look, there are advantages, disadvantages. Sometimes these patients end up not smoking because they have cracks in their ribs from the from pathological fractures. And then they'll say, well, maybe I can use it in another way. Okay. And yeah, and then we maintain the communication and go on with the treatment. So one form is inhalation, and the other form is using extracts, primarily diluted in oil. This is not the highly concentrated preparation that is supposed to be effective as a anti-cancer agent. Okay, and we explain that normally these are small drops that are dropped under the tongue or in the gingiva, between the lip and the gingiva, and then it's absorbed locally and more consistently than if it's ingested. Because when it's ingested, then it has to go through the whole hepatoportal circulation and is transformed. The effect is different, it is less consistent, but sometimes if there's no option, we say, okay, rather than not take it at all, you can take it like that. So we explain these options to the patients, and we explain how they can access it and try to answer all the questions while balancing the expectations, and then we have to follow them up, okay? Because sometimes the initial preparation they get is not appropriate for them. Sometimes they cannot fall asleep, sometimes they are drowsy all day, and then we try to help them find the appropriate regimen. We adapt it to their daily routine. Some people will avoid it during the day when they want to go to work, and then when they come back home, then they take an immediate dose of cannabis, and again, let's say before a meal, because it helps them eat willfully without, spontaneously, rather than forcing themselves to eat. It improves the swallowing a bit, and then maybe again try another species for sleep at night. I think one of the issues discussing all that I've said now has to do with, well, convincing the medical community of the credibility of using cannabis, because as physicians, naturally, we have seen a lot, and we tend to be skeptical, and with good reasons, because we have been disappointed and we have been misled from time to time, either by the disease or by the patients. And I cannot provide you any scientific data, but these cases, these observations, are consistent throughout my experience. I try to be as honest and forespoken as possible, and to give you at least a sense of credibility of what the patients describe when they tried cannabis on their own, and to be open-minded to test it. The way I entered the world of cannabis, I never had any ideology or preconceptions. I simply observed a number of remarkable responses which could not be achieved by any other medication. And having the opportunity under the specific unique circumstances in the Israeli medical system, I decided to go on and learn about it more. I guess I'll halt here, and I wonder if any of you have any questions or remarks. Just a sec, they want to give you the microphone. So.
Hello. When getting a conventional therapy, is it a good idea to use cannabis oil at the same time?
The question is what kind of conventional medicine therapy, but cannabis is definitely an add-on. As I said, sometimes it spares a lot of the other supportive medications along the way. For example, as far as sleep and anxiety is concerned, you can discontinue the SSRIs, you can discontinue the benzodiazepines, and people will still be sleeping and feel relaxed. As far as pain control is concerned, you can improve their situation by decreasing the opioids. And there is a certain degree of synergism in the analgesia achieved by the combination of opioids and cannabinoids. And I mean, there are basic science observations and studies that support that claim. So naturally, we provide it together. Topical cannabis is also an issue in itself. Actually, it is not authorized in Israel for a very odd reason. Topical cannabis, as I described on the breast, was useful. We have a lot of difficulty with polyneuropathies, with severe dysesthesias in the feet, and you can apply it locally and sometimes it will help.
Hello, I'm Dr. Predrag Nikolic from Serbia. I have actually two questions. First of all, you mentioned that your patient, according to Israeli law, can use cannabis through the inhalation or smoking. My question is, what is percentage of THC and CBD in inhaled or smoke? Okay. And second question, do you have experience with cannabis oil? In my area, in Balkan area, you know, 16 years ago, NATO stupidly bombing Serbia and with and poured uranium, and we have now the biggest rate of oncology disease in Europe. I'm also not only doctor, I'm also patient. My diagnosis is mesothelioma malignum, and when official medicine hit to the wall and no answer for my disease, I used cannabis, but I use as cannabis oil and put it sublingually. I decided to choose THC percentage between 25 and 30%, and CBD 40%. Now I'm okay, but my disease was metastasized to peritoneum and pericard. Now I have no any change on peritoneum and pericard. and in pleura in retreated, in remission. And my question is that what is the percentage? Do you know? Do you have any record about percentage THC and CBD? And what is the better option, the best option for your patient? And your experience with the cannabis oil?
Mm-hmm. So, well, the percentages vary, especially in the plants, and despite attempts to regulate it. Obviously, there are seasonal variations. It is improving gradually, and there are some companies who are doing better and some are doing worse, but we are experiencing fluctuations in the efficacy of the cannabis for various indications. But then if we are using oil nowadays, we do have certain concentrates. It varies from company to company, and we have to take into consideration the manner in which the oil was extracted. So and the different species that are used, because each company is providing concentrates from different species, and it is not just the CBD and the THC. When we go to higher doses, it is essential to add CBD, otherwise the THC effects are too dominant and the people cannot function as they would like to during the day. That is my experience. The doses go from 25 up to 40%, something like that, of THC and CBD. It depends. There are some variations now, but it is not completely under control of the doctor nowadays to dictate that. So what happens de facto is that we titrate the treatment clinically, and when we see the symptomatic response, then we are satisfied, and if we do not, then we move on to the next preparation that is available and try it according to certain guidelines. So if we want more CBD or less CBD and so on, of course. These are primarily oils. In the oils we know we have a better idea of the concentration of the active ingredients. We do have certain strains we know are more or less half-half THC, CBD, or very few strains which are virtually uniquely CBD containing flower buds. The oil, we use oil for several things. We use it sublingually. If we are talking about using oil for cancer therapy per se, both according to the common culture, the Rick Simpson story, etc., and some experiences here and there by patients who improvise on their own, then they take much higher concentrations and they ingest it. We also use the oil topically because for some odd reason we do not have the permission by the state to prepare creams or ointments, despite the fact that it appears both to be effective. Obviously, it has no psychotropic effects. Yeah, that's about what I can say.
Mám pacienta, který má indolentní lymfatickou leukémii. Jedná se o malobuněčný B lymfom. A teďka jde o to, že klinika je naprosto nulová. Ten člověk není unavený, nemá teploty, nemá infekty, prostě je to normální člověk. Přišlo se na to náhodně, laboratorně.
Okay, just a moment, maybe she can translate.
No problem, I will translate. Just to say that I have a patient with indolent lymphatic leukemia. This is a small cell B-type lymphoma. An interesting point is that from a clinical point of view, this person has no problems, no fever, no infection, no fatigue. This diagnosis was only found out on a random lab test.
Přesto má nastoupit na chemoterapii. Myslíte, že by bylo lepší napřed zkusit konopí?
Despite of that, this patient has been scheduled to start chemotherapy. Do you think it might be better to give him cannabis instead?
Well, I'm a palliative care specialist, so I couldn't tell much about hemato-oncology. You know, from a formal perspective, what I could say is that obviously this is a call of the specialist. And it touches, of course, on the trust and the faith we have in the knowledge that he has gained through his training. From a practical point of view, I know, and it really depends on the patient, it is possible to see some patients in such situations who insist on going and locating cannabis to use on their own initiative. As physicians, there's nothing that we could do except perhaps avoid incriminating such a patient and being aware of the fact that she is taking such treatment and monitoring her disease. I don't know. Obviously, from a professional point of view, I am not, as I said, the professional to determine what should be done and what not.
Jestli mohu, nechala jsem udělat druhý náhled, takže jeden hemato-onkolog říká ano, chemoterapie, druhý erudovaný hemato-onkolog počkat, zatím ne.
Yes, I've asked, as a professional, I've also asked for a second opinion from a second well-reputed hemato-oncologist. So while one oncologist says yes, go on for chemotherapy, the other established one says watch and wait.
Yeah, well, what can I say? That's life. This is not something that is unknown to us. And these are dilemmas, I think, that are occasionally dealt with precisely by palliative care specialists rather than the specialists themselves, who cannot determine whether to go right or left. And then we can do our part by trying to empower the people and see where their preferences lie. I think one of the roles of palliative care in the context of modern medicine is really to assist patients arrive at decisions, among other things, without intervening where they are not professionally competent, but in terms of really empowering the patient and help clarifying what is the issue, because many of the oncologists fail to do so, unfortunately.
Takže v tomto případě, když by se rozhodl pro ten kanabis, má spíš teda olej, anebo nějaký vaporizér?
In this case, should the patient decide to take cannabis, would you rather recommend a cannabis oil or some kind of vaporizer, inhaled cannabis, if he so decides?
Well, I don't know. I couldn't tell. I'd have to think that over and see what the patient is really after.
Hi, my name is Simon, and I'm a physician from Italy. Just wondering if you have any experience with melanoma patients.
Yes.
Yeah, in the cannabis oil, improve the quality of life, improve the clinical course of the illness, prolong the life.
Yeah, well,
In your experience.
All I can say is, well, you know, it depends where it has metastasized, to the CNS, to the liver, to the lungs. Generally speaking, as a palliative intervention, it is often effective. I could not remark further on, you know, any oncologic effect on the tumor itself.
You didn't notice any restriction of tumors?
No, but
No.
you know, we haven't used the protocol that would be focused on achieving such a change. You're done.
Oh, yeah, I think so.
Okay, thank you very much for your attention.